So, welcome everybody. Welcome to this special panel. I'm sure you've been as excited as I have about all the amazing presentations we've seen over the past 2 days. I want to express my appreciation to our interpreter. Thank you so much. You all are working so hard. Perfect. This is a special panel that I would really like to express our gratitude for the organizers of HARC. I can't even count now how many times I've been at the HARC sessions, and this is our second virtual one, and I'm looking forward to the next in-person ones. So thanks so much to Lori and to Michael, of course, and the whole team for keeping this going from year to year. So I'm very pleased to have a special panel. I'm booming in from Tel Aviv, Israel, and my colleague, Professor Jürgen Pelikan, who's joined us from Austria, and Michael is here, who will be our trusty discussant before we open up to all. So I'm going to share a screen just to get us going, and thank you all for joining. Okay, so I'm just gonna, okay, I just shared, but I'm not sure if it's opening.
Not yet. I'm going to ask the tech person for support.
Okay, so I'm going to let's see if this is.
There you go. Yep, looks good.
Perfect. Well, good. Now let's get going. So thanks again. You see the names of those who are presenting here, who are our team members, but we really have a huge group of people who have worked together on this issue of digital health literacy over the past few years. So we're really pleased to be representing so many of them, and we wish they all could be here. Time zone issues and other issues will really prohibit them from being here, but they have contributed so much to what we'll be presenting today. So what we'd like to do is make the best of our time. And firstly, we'll kind of set the stage, talk about digital health literacy. Why are we talking about? Why is it important? Where we've made some progress, what we can be expecting, we think, what are our projections, and why does it need to be measured? Then there will have a more in-depth look at the MPOL study, which you'll get to know very closely, and particularly let's see the digital health measure results that we've been working on, get our perspectives, understand maybe the recommendations that will come out of this for improving digital health literacy and for seeing an appropriate response from all of our organizations and our policymakers. And no less importantly, we would like to have a lively discussion with you all. We're really pleased that Michael Pasciorlo has joined us to be our kickoff discussant. And we really want to get as many of your perspectives as possible. We will admit this was originally going to be a workshop, but we got really wise advice from Lori and the rest of the team saying, let's turn this into a panel and still keep it as interactive as we can, because this is a really important topic for discussion that touches all of us. So where are we going? So first, this is kind of we're going to take a look at kind of a global perspective, maybe the US perspective, European perspective, and then really dig deep into where we are as health literacy advocates, experts, researchers, practitioners, etc. So just take a look at where we were in 2016. This was data before the pandemic. As you could see, almost the entire Northern Hemisphere was online. The percentage of people not using internet was very low. And we know this has only gone much higher. And we even know that people, even from the areas where there isn't much internet, we know that the mobile access is even more accessible to them for many of their countries, more than electricity and more than water. And who is online? Actually, who isn't online? But we're seeing, as I mentioned, that the mobile lines are really going to be, and they're going to be more and more relevant for all of us, for all the work we do, and for managing our day-to-day lives. What's going to happen to the market? And I guess as practitioners, as researchers, and as policymakers in health, we don't usually look at marketing data, but I thought it would be a good idea to share some of what we're seeing here, because if these are the projections firstly in the European market, to see where digital investment will be. And what is it? Why is this important for us before we look at our professional work? Is that it means that more and more resources, more and more capital, more and more money will be invested for obvious reasons in the whole digital health market. So that means there's going to be more and more apps, more and more digital healthcare, and much more hopefully accessible areas in which digital health is going to be offered to the public. Well, the question will be, what does that mean for the public, and what it will be their perspective? Why are the resources going to be only there and perhaps not enough, which maybe in our recommendations we'll talk about where we can also think about using our research or using our results to help see where some of these resources can be also invested in the people and in the public and in accessibility. That was the European trend. Let's look at what's going to be expected in the US, no less. This is, of course, this is dollars. And we're seeing, what you can see here also is the telehealth care, which we've seen so much of in this conference. I've really been so intrigued by the presentations yesterday and today where we've been talking about telehealth. It's very exciting to see some of the work that's being done by people who are attending this conference. But if you can see, if you take a look at the purple here and you see what the trends are for telehealth, it's expected to get larger, but take a look at what's going for mHealth. It looks like to me, and probably to you as well, the rate is getting, the rate and the proportion is even larger, and that's going to be expected. So let's keep this in mind when we talk about the rest of our session today. Also, if we take a look at the health systems themselves, it is expected that they will be more and more digital. And this might be good news, it might not be good news. We'll let you judge, and we'll keep the discussion going. Okay, so just to sum up this first short part, I guess it's obvious to all of us what the advantages of digital health are. We know it overcomes distances, even though I was really interested in hearing some of the colleagues yesterday talk about what's going on in the States, where the digital health and telehealth doesn't necessarily cross state borders for reasons of billing, but we know, at least where I come from in Israel and where we work in other countries, it's one of the beauties of digital health is that we don't have to worry about geographic grouping anymore, and just think about what's going on here in our conference, where digital resources have helped us all come together. So we know it overcomes distances. We have to use that to our advantage and not still keep the distances or keep the borders up if we don't need to. Overcome language barriers if we use the system right. If we do telephone translation, if we do translations while we are working digitally, it would be able to overcome some of the language barriers and also the economics of language accessibility. Conveying real-time information. We know that this has been a challenge also when we talk about vaccination, and maybe it's been too real-time. It's been to our advantage as professionals, but maybe the public is saying this is changing too quickly, and what does that mean as far as trust? But it also overcomes patient-provider barriers. We've seen it in almost all of our countries during the pandemic. As it was mentioned yesterday in some of the most engaging presentations, I think Michael Wolf also and his group also talked about this yesterday, where there was a little bit of patient provider digital work before the corona. It expanded 38 times and even more so once the pandemic came, and we saw that as well. What we thought would be impossible or challenging, it was challenging, but we overcame the challenges so quickly, and much of it is here to stay. We can expedite the navigation of self-services because maybe some of them will be digital and just be easier to click on and get to our consultants and get to the services where otherwise people have to get on a bus and pay for transportation or have a spouse take them or not be able to come because they're not, the physical service is not culturally appropriate. So maybe it will expedite it, maybe it can, and maybe it is, and maybe we will have that in the long term. And it can be cost effective. We've seen this for some of the health promotion programs we're running, which I'll mention. And of course, we know that there are some disadvantages or some barriers. we've seen it in our work in Israel, privacy and confidentiality, even though we've overcome it, we happen to use in our system, in the Clalit Health system, we're using Microsoft Teams. It's just only the reason we're using it, not Zoom and not other systems, is because of security. And we thought we're doing pretty well. But when we talk to the public, some of the cultural aspects of this were that people were worried that maybe a family member was listening in on them because they were at home talking to their provider. And it wasn't just the system that we had to worry about, or that we do have to worry about, of privacy and confidentiality, but also what the setting, where people are when they're using digital health. And this is something we didn't think about ahead of time, and we're trying to help people find that safe space when they do access digital health resources. The issue of credibility, that is when we have the health information, what is it trusted? Who are the sources? So much information is coming to people from so many different sources. And we know this so well with infodemics. So we have to make sure that we're keeping it credible. Usability, obviously, the systems are getting easier and easier, I think, but still there's a lot of issues of usability for people who don't have the confidence. And that's part of what we should be doing. We'll talk about this at the end, hopefully, for digital health literacy. What can be our role in making it more usable, and making people feel that self-efficacy in digital health. There is issues of accessibility as far as technology. Do all of our rural areas have broadband? Do all of our villages who we work with have broadband? In the homes, do they have to go, people have to go outside to get it? Do they have to go to a public area to access broadband? These are real issues. For many of us, maybe we don't realize it, but when you go into the field, people talk about that. And then the issue of common language, not necessarily a language of Hebrew, Arabic, English and all, but also, do we have new jargon? Do we have new acronyms? Do we have codes that are being used, and people might not know that? And maybe digital codes in one part of the state are different than others, or one system. And, also not every country has universal health coverage. We are lucky that we do in Israel. So we have a common language when you talk digitally, of course, in our language, but also from system to system. But I am very aware that many of the places you all work, there isn't that commonality and that consistency from system to system. So, and of course, when we talk about digital health, we have the ecosystem, and I really like using this graphic that I borrowed from the hitconsultant.net. You have it acknowledged on the bottom of the screen. It really just shows when we talk about digital health, we are really talking about dozens and dozens of formats, whether it's the apps, which we know are getting, we will be seeing more and more apps. We're not necessarily seeing how effective they are for changing health, or changing health outcomes, or health behavior, which is what we work with in pretty much in health promotion. But they will become, we'll be expecting to see more and more. The digital devices, the medical devices, the internet, Internet of Things that we know is becoming more and more popular, particularly in the health systems. I know in our system, again, Clalit Health System is the largest health system in Israel, nonprofit, and we cover 54% of the population, and we're kind of at the forefront of those who want to test devices. We have now home testing for urine. We have home testing for diabetes, we've always had, but also digitally, people will be able to have a home ultrasound, a self ultrasound for pregnant women. So think about what that means as far as self-care, as far as using systems in a way in which are actually medically evidence-based, and people have confidence in it. And all we need to do is just send the ultrasound to the gynecologist or the OB/GYN person, and they will be able to interpret it within an hour, call you back and let you know how you're doing. And this is what we're doing now in Clalit. What will that mean as far as people's confidence or as pregnancy health? We'll be following it. So I think we'll be seeing more and more, and of course, more and more monitoring of people's health from remotely. And we could have a whole panel on this, but I will move on. And then the issue of wearables for people to get feedback, immediate feedback about how they're doing, not just the classic pedometers, not just the classic, polar or whatever watch, but we'll be seeing more and more apps and more wearables to help people understand how they're doing with their sleep and stress, et cetera, et cetera. And I'm sure you all are very aware of it. So when we talk about digital health, look at really the huge menu of formats that we're talking about. And it isn't one size fits all with any of what we're measuring necessarily. And you'll see the challenges when we talk about what we've measured. So, how is the public using space? This is also data that's come in for how people are using, how they're, for example, how they're making appointments. More and more providers are actually offering the way in which that people can make appointments. What we're seeing in some of the research, it's been consistent, is that people, to be able to find a provider, are going to the virtual space, but to make the appointment, calling and still using the telephone. In Israel, it's doing both. It's also finding getting the referral digitally, and also making more and more making digital appointments. But it depends upon the culture. And just a huge study has just come out of comparing people coming from the Arab background, or from those who are more the Jewish background, or the mainstream public in Israel. And there's different uses, different issues of trust, and different preferences. So even when we're measuring at a national level or doing a survey, we really have to look at the special populations as well. So also we've seen, this is also data coming out of Google, who's providing us with a lot of the data because they are collecting the data. How is the public actually using? We see 5% of all Google searches are health related. So moving from the issue of providers and healthcare, of course, the health information, which is always the initial use of internet for health, people are still using it more and more. We're actually analyzing in Israel and seeing what the main issues that people are looking at. When we assumed, for example, that the main issue that people might be looking at would be sexually related or something sensitive in that area, we found that the topic people were most looking for in Google was depression. So, it's really important to look at this data and to look and see and get the information from those who are collecting from the search engines. 94% of the healthcare patients use online reviews to evaluate providers from some surveys. So what does that mean as far as how people are critically looking at the health system using digital tools? And 84% of the consumers trust reviews regarding providers. So more and more people were doing kind of crowdsourcing and people consulting with others. What have they seen about this physician that we're going to see, or that dietitian? What are other people's opinions about them? Are people like me? So social media has really come in on this. And then, finally, if you look at where digital is helping us as far as what we're doing in health promotion, we're doing more and more online group work, for example. So our interventions, and it's not only patient provider, but it's also meeting the public when we would be doing so in a primary care space. We began doing it initially when the pandemic hit. We had thousands of people registered and involved in group work around the country, and we immediately had to shut the groups down. And it took 2 or 3 months before we got a system going. But we realized people were still so hungry to participate, and moderators and group leaders were interested in being retrained. They weren't necessarily preferring it, but they wanted to keep and we still want to keep it all going, so and keep the interventions going. So as you can see, this is just some data we have from over the past year. Over 120 group sessions on smoking cessation. As you can see, lifestyle and weight loss, diabetes, breastfeeding, birth preparation. We have also long COVID groups now that have been established of people who really need to work with other people and listen to other people and not feel alone, but not necessarily feel they want to come to a clinic to do that. We want to make sure that we're still maintaining the COVID prevention guidelines. So we're using those digital spaces to our advantage. We can also do it in Russian. We can do it in Arabic. And maybe when there was places where we didn't have enough people in one geographic area to do those group sessions in a special language. Now that we're doing it digitally, we're able to get people from different parts of the country in one group, and that has been to our advantage. So these are just some of the numbers. We're following this to see the effectiveness. Just as a quick spoiler, we're seeing that, for example, smoking cessation effectiveness is just as effective when we have the same quality group leaders and cessation advisors online or in person. So we're happy to see that we're maintaining the effectiveness. And the other topics here, we're still looking at the outcomes. So then came vaccination. So in the vaccination rollout in Israel, of course, we tried to use, and we are using the digital system to our advantage. We tried to make sure that we're clocking and monitoring any of the infodemic that's going in and anti-vaccine messages that are not to the public's advantage. We even had a meeting about that this morning. And this is so actual for us, and this is so relevant for us. We're still working on it, as all of you are as well. How we can get the best message across reliably with trust, and even make sure that those who are giving the message are in a secure space, because we're also seeing for the first time some potential aggression that we're not going to make sure, we're making sure that even digitally, we're trying to make sure that the language is empathetic. We're looking at emotional literacy also to make sure that people understand that they're concerned about vaccinations when we're starting to roll out children's vaccination. And so this is an article that we published. I was really grateful to do this with Scott Ratzon. And so we're learning from week to week what the best way to do it is. And then the infodemics, which you all have seen from the beginning of the pandemic. We didn't really talk about this before the corona pandemic. And it was probably there, but we didn't see it enough and we weren't paying attention. So the spreading of misinformation from the beginning, you knew, as all of us did, there were so many different messages that people were getting, and some of it were well-intentioned. You know, can use a hairdryer, our sun will, being exposed to the sun will prevent COVID. Remember those? Doesn't it seem like a long time ago? It was just a year and a half ago. But now we're seeing fabrication and some of the interests of those who are giving messages to the public digitally don't have the public's best interest in mind. So just another point in our orientation is the issue of the life cycle, and also where we're going, who are those who we really want to target. And I think we've all come to the conclusion that this is really a life sequence issue. If you're seeing that 6-month-old babies are using tablets and smartphones, there's more and more data about how children are using, particularly because of the pandemic. We're concerned about it as far as children's and adolescent health, but the American Pediatric Association is constantly coming out with position statements, but we see it from the earliest age. We know that digital information, digital resources will be here to stay. And when we know that for looking at what used to be in adolescence, coming together about reading a book or watching television, we know, of course, that it's mainly now going through digital, from digital communication. And one thing that we're all looking at very closely, and there was a great session about this yesterday. I just loved participating in the session that we had about the telehealth and the informatics. Digital health in older adults it is a new normal. We assume it'll be a new normal. We just published also in the Encyclopedia of Gerontology a chapter on digital health. And I think one of the challenges we have with digital health in older people is removing stigma that our systems perhaps have about older people's use. So we're seeing more and more baby boomers, of course, using it like the people who are younger, and even those who are coming, quote unquote, from the silent generation, who are over 75, they will soon be those who were 60 and 70 and using digital resources. Plus, we're seeing that there's digital opportunities for them that there weren't in person previously. So there will be digital solutions will help people access information, providers that maybe previously they weren't doing. And there's just some really good research coming up, and here's some of the references. So, so why are we concerned? And we need to keep our concern very active. And there is a two-faced debate. Does digital health widen or narrow the digital divide. I put it in quotes because the phrase has become kind of second nature. And I think we have to make sure we revisit this a lot, because we are seeing that there is, as we see through the life course, maybe we're talking about digital development throughout the life course and not just digital divide. Is it black and white, or are we seeing a gradient? And soon you'll be seeing some data that maybe will help us answer those questions. And does the digital health trend provide more opportunities for people to promote their health, or is there more exclusion? And of course, there isn't one answer, but these are the questions that whether we're looking at policy, research, or practice, we need to keep this debate going, and our concern and our attention needs to be focused. So as you see, there really could be the advantage from childhood to older age, or maybe there won't be. So we'll have to keep looking at it. But as health literacy advocates, experts, practitioners, policymakers, public health, with public health and healthcare in mind, we promote looking at digital health literacy in general, and specifically digital health literacy as an asset. And how can we learn about it as an asset, and how can we promote it as an asset for health? So you all know this, and that's why we need to measure it. So you all know the health literacy definition, of course, by Norman Skinner, and the original definition of the Lilly model was called e-health literacy, and kind of evolved into digital health literacy, but we can still call it e-health literacy. It depends upon our context. And of course, you know the definition, and I don't even have to repeat it here. But the question is, why are we still, are we taking these definition to the extent that we need to, as far as having all the electronic sources being covered? And in revisiting this, some have said that we need to expand the definition and look in different ways in which that we measure. We know that digital health literacy, through the tremendous research that's been done using the HEALS measure, which many of you know, we know that age influences health status, educational background, digital literacy skills, motivation. This came out from the early studies. But let's remember that when this definition was established, we were looking at Internet 2.0. So it's become much more complex. This is a model that my colleague and I, Isabella Bertucci, I'm grateful to work with her. We published this model because looking at all the literature that we were able to review, we realized that there are different contexts, and the context can be personal, they can be situational or environmental, as far as the extent to which people are using digital resources and have digital health literacy skills. It can depend, of course, we know, on the socio-demographics, which is obvious. We know it also has to do with individual specific skills, the numeracy skills, language proficiency, and technological experience. It can be situational. Things change throughout the life course, and they can go back and forth, particularly because of health concerns and health situations. And then also for the media environment, what are the access? Is there usability of digital tools? Is it relevant to the different populations? Do people feel it's relevant to them? Is it part of their norm in their culture? And of course, that brings us to the social environment. So as you can see on the bottom here. So we actually think that this is a helpful model to help us realize not only the complexity, but the different parts and the different aspects of digital health literacy that we should be looking at when we do our research and also when we do our intervention. So this is another model that has come out, and you have the reference below. I like the way this is graphically spelled out. Again, it's looking a bit more looking at digital literacy, and we can look at it and say, let's just put the health part in each of these, whether it's information and creating innovation, the technical proficiency, digital identity and well-being. Are they safe and secure? The communication, and collaboration and participation. Does it allow people to participate and connect up with others? And then is there teaching and learning and self-development? So I'm bringing these different definitions in so that you can see that it really kind of all comes together for have the same components, and they're kind of joining up of the different aspects, whether it's person-centered, and we'll be seeing soon organizational-centered digital literacy. And unfortunately, in parallel to us, there is the organizational health literacy panel, which I would love to participate in as well. So maybe next year we'll do something together. So then we have the research, the very important research, the landmark study that was done by our Dutch colleagues, looking at a new way in which to measure health literacy or digital health literacy, using the European health literacy concept of asking people how difficult or easy it is, or easy or difficult it is for them to access, to understand, and to use information that they're accessing digitally. So this was a kind of another move towards a more complex and a broader definition of digital health literacy. And this kind of promoted our discussion forward. And what we saw as a group, which you will meet soon through Professor Jürgen Pelikan's presentation, which will follow mine, is that we realized that this instrument that I just mentioned, an important breakthrough in looking at digital health literacy and measuring digital health literacy. And of course, didn't mention it, but also any of you who know the research, they saw that it was aligned with health literacy that was measured through the same concept. So it measured the following aspects of digital health literacy. We saw that it was looking at operational skills and navigation skills, information, evaluating reliability and determining relevance, and adding content and protecting privacy. It did not look at the issue of trust, but as I mentioned, we are grateful for that research because it helped us build the research that we looked at. So in summing up from this part, digital health literacy is obviously increasingly important to helping people access health information and interact with health in public systems, including navigation, and also manage their personal and their family's health, and maybe also their workers' health that they're responsible for. It does entail skills related to all aspects of health literacy. And if we look at the NUTB model to help us think about this, so the functional, interactive, and critical health literacy, there are social, cultural, and generational contexts that play a role in digital health literacy skills. And appropriate and innovative interventions can positively influence digital health literacy. We'll take a look at this towards the end when we discuss, and contribute to health and well-being. And of course, we're all looking globally at the principles of the UN Sustainable Development Goals, because we want to make sure that in the increasingly digitalized world, it probably won't be going back to being less digitalized. We'll see. We want to make sure that no one is left behind. So in spite of the emerging importance, it hasn't been measured and hasn't been monitored in very few, if any, national surveys. And therefore, the MPulse study we thought it was an excellent opportunity for evaluating digital health literacy and to learn of the association of digital health literacy with health literacy, sociodemographic, economic barriers on the population level, and much more. So I will stop right here for a minute and just kind of pause. Take a deep breath for all of you who have been following this, kind of went through a huge amount of material at once. I'm going to stop here for a minute and just see if anybody has any comments or questions at this point. We'll take a couple minutes before we keep going in our panel.
Sure, Diane. There's a few comments from Jerry Bomblatt, in particular, pointing out the difference between synchronous and asynchronous scenarios. There's a whole topic there, and what and how these things impact privacy was one of the angles she was bringing up in her comment.
Yeah. Oh, thank you. Firstly, please add your comments, your questions. Take part in this panel through Q&A and through chat, and we'll be following it. Thanks, Michael, for that. And thank you, Jerry. It's really a huge question. And the issue, on the one hand, asynchronous is important for people to be able to choose when and where that they want to access digital resources and feel safer. And I love your comment. On the other hand, if they want to have the response, whether it's an examination, a diagnosis, a recommendation, healthcare question and answer, and still capture as much as we can of seeing faces at the time when we're interacting with our providers or anybody who's helping us through a health issue, whether it's on social media or not, then we want the synchronous digital resources to be available. So so thank you for mentioning that point. And I see that Michael is also.
Well, there's another topic that's come up is how do you distinguish between a DHL issue versus like just shitty design, bad user experience? There's sorry if I put it that way.
That's okay. At the end of
there's about 350,000 health apps,
right?
But most of them are not good. Mm-hmm. And in fact, I think the average, like even things that get downloaded, many don't get downloaded. They get touched 3 or 4 times, and that's it. And so this is the two-sided coin that we frequently deal with in health literacy. I think maybe Jürgen will talk about this more as well, but at least maybe if you would take the opportunity to talk about, where you see DHL as a construct to help this conversation versus, focusing on improving design.
Yeah, I thank you for that comment. It is a dilemma in places where we aren't taking responsibility and we're not producing some of the digital health resources that we want to recommend to the public. I'm very fortunate that I work in an institution in a country that we're able to say or to take responsibility or actually recommend specific digital resources because we produce them. And maybe it's Startup Nation, or maybe it was just a decision that was taken. But if we want to, we have for example, an app that's called 40 Weeks, and so pregnant couples can go on and see what's going on week by week, and we take responsibility for that content. And we also check to see if it's clear. I've commented and we changed some of the language that I thought was too stigmatizing, some of the gender issues. So we're trying to keep quality assessment going all the time. And in doing so, we can say then we recommend this. We can take responsibility for people going, and then we can look at the digital health literacy issues because we're saying, okay, we're hopefully helping people access something that we feel is a good design, never perfect, content that we feel is evidence-based and accessible. Maybe the language, we've checked it, not perfect, but we have to make sure that we keep making it better. And so we're taking responsibility for that. And then we can say, okay, so, but what are the skills people need to use it, and then address that. But I say we're fortunate, and I don't think all the systems are that fortunate that can say, you can do whatever you want to, but if you want to go to an app that we think is the best and is in your best interest, and we're making sure that it's got the best content for you, if we're not in that position, then we do have a problem. And
right, so there's content, but it's also like whole user experience.
Exactly, it's user experience, it's design, it's content, and some of it is all well-intentioned, it's just not updated. It's a huge issue. What is being maintained on these systems? Some of it was perfect when it was launched, but nobody's maintaining it, or it was a project, and then the project money went out, and then no one's maintaining it, and people are seeing it and using it and not knowing that it's not something to their best health. So I think what we're going to have to do, and we can also talk about this at the end, is help people understand how to judge. And you'll see it in the study that that Jürgen was presenting now. Help people judge and sense that they have the capability to judge and the tools to judge whether a certain digital health resource is good for them. Does it have this? Does it have that? Is it, you know, has it been updated? Is it a source that you feel is reliable? Does it talk about people who are people like you, whatever? But we still have to be careful because the commercial world is also knows what we do also, how to make people access resources to help them understand and feel good. And so it's tricky. I don't think we have all the answers, but I'm so glad we have the questions now. A few years ago, we weren't asking that question because anything that was online was considered good and considered even by the public, especially by the public, credible because it's written. And more, I think the public is, we're seeing is realizing that because of infodemics, because of the concern, that not every digital resource is for their best interest. So I think a lot of it will have to, part of it will come from the systems themselves and regulation, perhaps, standards, but also have the partnership with the public about this issue. But we'll have to keep talking about this, just keep the discussion going. So I think having said that, I would like to move on to the next part. And I'm really so happy to introduce my close colleague, Professor Jürgen Pelikan. Let me say a few words about Jürgen. Many of you know him, many of you know his work and his group's work. And maybe you've met him also at HARC meetings. But he's a professor emeritus of sociology at the University of Vienna in Austria and director of the WHO CC for health promotion in hospitals and healthcare at the Austrian Public Health Institute in Vienna. He's co-initiated the European Health Literacy Study, the HLSEU, and he was the principal investigator for data analysis and reporting. He directs a lot of research on health literacy for specific populations, and health-literate healthcare organizations launched that concept in Austria, and the principal investigator for the EU project on diabetes and health literacy. He's a co-editor of the WHO publication on health literacy, The Solid Facts, which was one of the landmark policy statements and publications of the WHO in health literacy, and co-chairing working group on health promoting hospitals and healthcare organizations. The health promoting hospital concept, I think, was really Jürgen's initial. It was Jürgen's initial. I'm just getting an interesting message now. It was his initiative, and it's been going for 25 or 30 years. And he also is a co-chairing of the Action Network for Measuring Population and Organization Health Literacy, which is the MPOL network and study which we're presenting now. So, and he's also an executive board member of the International Health Literacy Association and Scientific Advisory Board of the Asian Health Literacy Association. So he comes to us here with so much rich contribution to the whole area of health literacy. So I'm very happy to be working with him on the MPOL study and to leading with him and a few others, the whole issue of digital health literacy. So Jürgen, over to you.
Well, thank you so much, Diane. It's a real pleasure to work with you, and thank you for this very kind introduction. Listening to that, I really felt, well, when have I done all these things? I must be very old that it is possible that I have done this and try to do that. Well, but now I have the pleasure to talk to you and to present you with some results concerning measuring digital health literacy for general adult populations in the Health Literacy Survey 2019 of the WHO Action Network, MPOL, which Diane just initiated. Well, you see, I'm talking for a working group which was led by Diane and by Stefan, but we from the International Coordinating Center, of course, helped to provide and to proceed with this optional package. Next, please. Yeah, you see, the optional package of digital health literacy is part of the HLS-19 study, and the HLS-19 study partly is based on the HLS-AU model and definition of health literacy. I just remind you of the definition here. The important thing of this definition is that there is a conceptual matrix for defining domains and information management for tasks of health literacy. And you see we have this matrix where we have 4 steps of managing information, finding it, understanding it, processing it, applying it, and then, of course, the information is related to topics either in healthcare, in disease prevention, or health promotion. That's one thing, and the other thing, we have a more or less simple generic model of health literacy, defining principal determinants and consequences, and we use this model here as well. Well, there are personal determinants of individual health literacy, and of course there are situational determinants. Individual health literacy then can have direct effects on health behavior, and indirect and direct effects on health status, and effects lastly on illness behavior, and of course by that effects on healthcare costs and as well. Next, please. Yeah, as a design of the MPOL's HLS-19 study, I do not go into the research questions here because I will talk about the specific research questions of the optional package. Important, what is the survey design? It's a cross-sectional national survey for resident populations 18 plus by probability samples from a minimal 1,000, well, different countries had from 1,000 to 5,600 respondents by collection of data between November 2019 and June 21 by national agencies. And it took us, because of Corona, it took us this long period of data collection. We had planned a much shorter period. And partly due to Corona as well, we had to accept very different kinds of data collection, PAPI, CAPI, CATI, CAVI, or mixed ones. And we did it in 17 countries. And here you have the countries from Austria to Slovakia. I only have to say something about the instruments. You see, questionnaires were developed in English language, translated into languages of the 17 countries. We had 3 kinds of measures for general health literacy. One, the Q12 for every country, and some country used more enlarged measures with 16 items or with 47 items. And we did it for specific health literacies. The format of our items is how difficult is it for you to deal with a certain task? And the answer possibilities are easy, are very easy, easy, difficult, very difficult. And we had 4 optional packages on digital health literacy, communicative health literacy, navigation health literacy, and navigation health literacy. And I don't have to talk about the data analysis. You will have it when I talk about the results. Next, please. Yeah, I will talk a little bit about the definition, or give the definition. I tell you about our research questions, about the countries which were included in data collection. We will have a look at the distribution of single items of the measure. We will look at construction of scores and psychometric properties of the measure, because it were all new measures. Therefore, it was very important to validate very carefully the psychometric properties of these measures. And we will have select results concerning distribution, determinants, and consequences of the measure. And there will be a short summary of main results and a discussion of these. Next, please. Yeah, Diane talked about the various definitions which already have been there. for this working group try to building on that to define a little bit more complex definition, and the more complex definition is the HLS-19 concept of digital health literacy includes the ability to search for, access, understand, trace, validate, and apply online health information, the ability to formulate and express questions, opinions, thoughts, or feelings when using digital devices, and frequency which people use of different health resources from digital sources. Here's digital sources, unfortunately, is 2 times, and resources such as online video consultations, digital personal health records, social media, health-related apps, etc., for promoting health. That was the underlying definition. And our research questions were, what are the psychometric properties of this new 8-item scale? How is the scale and the score and the items distributed in general populations and in important subpopulations? How closely are digital health literacy and general health literacy measured by our instrument? To what extent are the related traits of digital health literacy and of general health literacy empirically different? Because it's important, because I think we could have a discussion later how far should we go? We have general measures for health literacy, and how many specific do we want? How many flowers do we want to have? How complex and how differentiated and various should our health literacy measures become? Therefore, I think it's very important to have very good reasons to have a new measure and to have a specific measure and not use a general measure. Then there was one research questions: what are the significant determinants of digital health literacy? To what extent is there a social gradient? How is the scope of self-reported usage of different digital health resources for promoting health related to digital health literacy? And of course, what are relevant consequences of digital health literacy measured with this instrument? And of course, I only can answer some of these research questions in this presentation. Next, please. Well, you see here the countries which were participating. All in all, analyses were based on 29,060 respondents with country-specific sample sizes from 1,000 to 3,602. There was a variation, as I already said, in data collection method, which of course is a problem, because partly difference of countries may be methodological artifacts. And these different data collection methods were used within countries, party countries combined. CAVI, for example, with CARTI, and of course there are differences among the different subpopulations. Next, please. Yeah, here you see the items which were used, the 8 items. And you see, starting with the most difficult item is to judge whether the information is reliable. The next is to judge whether the information is offered with commercial interest. And the third is to use the information to help solve a health problem. And the most easy item here or task is to use the proper words or search query to find the information you are looking for. And you see that within these 12 countries, the ranking of difficulty of these items is more or less, there's a certain trend, but of course with some deviances. Next, please. Yeah, here you have all the data if you want to know the percentages, how these items were answered in the different countries. And here you have percentages where very difficult or difficult are combined. And here we see that that the range is from 21.8% to 52.1%. The items differ quite a lot. And here you see, and I won't go into that very much in my presentation, the 2 other items which were asked concerning digital interaction. The one item is to express your opinions, thoughts, or feelings, ask a question in writing on social media, including online forums. And the other one, I clearly formulate your written message when communicating with a health provider. These two items are highly intercorrelated, but not very correlated with the other 8 items. Therefore, they were not included in the digital information scale, but we treated them differently. Next, please. Yeah. Here you see average percentage response patterns for all the countries. And you see that for all, and all is always weighted equally, these countries weighted equally, 8% answered these questions with very difficult, 30% answered them with difficult, 48 answered them with easy, and 15% with very easy. And you see already here that our instrument is not so sensitive concerning the better digital health literacy, but better for concerning that. And the other important thing to see, there are quite big differences between countries. For example, if we put together very difficult and difficult, in Portugal, it was 26%, but in Germany, it was 58%, which answered difficult or very difficult. So, and the other countries in between. Diane will be interested in Israel, where it's 7 and 31, 38%, somewhat within the other countries. Next, please. Yeah, new instruments for validation and psychometric properties. We use 3 methods of validation. The first and simple ones is Cronbach alphas. And you see that the Cronbach alphas for all countries are quite acceptable. On mean, it is 0.83, and the lowest one is Norway, I think, with 77. Yeah, so all are above the limit of 0.7, which usually is used for Cronbach alphas for internal consistency. That was the first thing. As a second thing, but we were a little bit more ambitious. We wanted a instrument which is more or less universal, unidimensional or one-dimensional. And for that, we did confirmative factor analysis with dichotomous items. Loading in a single latent variable was estimated for each country, and the fit indices generally indicate an acceptable fit in all countries. That's very important. You see, if you and that is a situation which you do not have very often, that you start with a new instrument and not just in one country, but you do it in many countries and many languages at the same time. And you see here that we were successful to develop an instrument which worked in all these countries over all these languages. And the third thing, because we had a very ambitious RASH team in our consortium as well, we were ambitious enough that we wanted that our measures are RASH scales, and therefore we did RASH analysis. And here again, the result is that concerning RASH criteria, our digital measure is sufficiently unidimensional. And to see some more things, no significant statistical dependence between and so on, between the pairs of items were observed, which means that no items are too similar and collect redundant information. So we can say we have a measure with quite good psychometric. Of course, the other thing is interesting here. I think we should just look at the mean, and we see that the new measure, the digital health literacy measure, is correlated with 0.53 with general health literacy, and it's quite highly correlated with other measures as well. For example, with navigational health literacy with 0.55. And here you see, I think it's important that we have these correlations in this size, because what does it say? it does say that digital health literacy is part of the family of health literacy. It's correlated enough with other health literacy measures, but it's not correlated so highly that it really has an independent and additional value for us. Yeah, therefore, I think that's very, very important to see how this measure behaves within the family of other measures, and more technical speaking, it's about concurrent discriminant validity of the measure. Next, please. Yeah, here you see something which is not so nice. This is a histogram of the distributions of our measure. Of course, one would love to have a more or less normally distributed measure. That is not the case. We have a measure here which has in most countries quite different distributions. And therefore, the measure is measuring much better for lower health literacy than for higher health literacy. I think that is the result of that. But I think for most political and practical purposes, it's much more important to be very sensitive concerning the lower health literacy than the higher health literacy. It's not. Yes, please.
No, your point is well taken. It's very, the benefit of discrimination at what's in what realm is. But maybe if I would specifically ask you to comment on Germany. It seems to be an outlier in a sense, in the form of not having this top code.
Yeah.
What does this mean sociologically from your perspective?
Well, first, I would say it's a methodological problem. Because in Germany, the data collection was different. It was done with PAPI, with personal interviews, with a much longer questionnaire. And they presented the items in a different way. They didn't ask questions, but gave people cards with the items on it, and the people had to rank these cards. Therefore, they used quite a different method, and not only for digital health literacy, but also for general health literacy. Germany has a different distribution, and in Germany, health literacy is worse than in most of the other countries. So it's difficult to interpret it sociologically only because there are too many methodological differences here, unfortunately.
Okay.
Yeah. And of course, you see, the problem is we had a multi-center study, but we didn't have any common money, and therefore every country had to find its own money, and we had to be rather flexible to allow countries to deviate from our study protocol. And of course, with MPOL, that became even more difficult. And Germany was, on the other hand, Germany had the money very early, and therefore they started very early. They started before the corona, while most of the other countries were in the corona period, and that might have had an influence on the results as well. But I think the biggest problem is here how the agency did the interviews. Next, please. Yeah, here I think it makes sense to just look at the mean column, and there we see that on average 62.3, and of course this measure says something about the percentage of the items which were answered with very easy or easy. But you see again here, there's quite a lot of differentiation. For example, Germany again with 41.8, and Norway with 78.7. And where is Israel here? Israel is with 62.7. So we see again that if we do a further development of the instrument, we need to include some more difficult questions. That would be good to do that. Next, please. Yeah, now we are looking into
Actually, Jürgen, I want to ask a clarifying thing that from what you just said. Yeah, you just said more difficult questions, but this is confusing to me because this is a scale that's they're rating
it's
themselves.
a scale from 0 to 100, and you see most of them are over 50. Yeah.
Sure, but the response options are not. Well, tell me more. What do you mean by having more difficult questions?
Yeah, but you see that we saw already when we looked at the distribution. Yeah, there is you see there's always I don't there's a technical term.
There's a skewness.
There's a ceiling effect.
Okay. That I want. You see, there's a strong ceiling effect, and the strong ceiling effect is there because there were not enough difficult questions in the questionnaire.
Yeah, but what is the concept of a difficult question in this context? I mean, yes, there's a ceiling effect. We see this but this is a.
That's just empirically. You see, it's empirically for how many people a task is difficult or easy, and we didn't have enough tasks included, which were difficult for many people.
If I can help here a little bit, it's the reason that I think what we're seeing is that our scale isn't sensitive enough to show a gradient in the area of difficulty, because people were seeing it. So many of the items were very easy for many of the people.
No, I see that. That's clear with the data, but the concept of the items are general concepts about like judging information, or they're not even if you said, I want to take one of these items, one of these 8 items, and I want to make it conceptually more difficult or less difficult, what does that even mean? This is all.
I wouldn't make one of these items more difficult, but we had to choose more difficult tasks. You see, that is my argument. We chose tasks. Yeah, we need more specific, more difficult tasks if we want not to have this kind of ceiling effect. But as I said, the ceiling effect is not a real problem. It's a statistical problem because we don't have a nice normal distribution of our score. Yeah.
Clearly, there's some countries with very high ceiling effect phenomena, like the Portugal thing, and you can see this. There's a lot of evidence of that. But I meant more kind of conceptually. The nature of the items are general processing of information, different ways of processing information, all meshed to the concept of the definition. And so what is it, to come up with like conceptually, what do you mean by a more difficult, not statistically, but in designing a question like this that matches to the definition, what do you mean by more hard or more easy? The nature of the scale is a self-report scale.
But you see, more difficult, for example, would be dealing with something which is very new and most people don't yet know it. Yeah, to include a new, how to deal with new kinds of apps or new kinds of media which are offered, which are not as well known as the internet, for example.
Okay.
Yeah, something like that. Yeah.
Okay.
Yeah.
And I think here, if I can maybe also just contribute a little bit, I think some of the questions here were very general. And if we divided them into different sub skills and more specific about different digital health resources, we could probably see a different type of distribution than we saw here.
Yeah, I agree with you. Yeah.
So one of the things here is that, the more specific you get, the more words you use in those claims, then you have you're introducing other phenomena like the linguistic complexity of the question.
Sure. Yeah.
Yeah. Anyway,
you are quite right. Yeah, but they didn't want to make it more difficult by using more complex language.
Sure, of course.
But more looking at more difficult tasks which are new and difficult. Yeah, for people. Yeah, that would rather be our. Well, but Diane already said we have to look a little bit not only at the distribution, but we have to look at associations, and here we are looking at possible at potential. Here we are looking. Yeah, that's something else. Sorry, we are looking here. Are there groups for which digital health literacy is especially difficult or low? And here we see people aged over 67 have 12 points more, 12 points less than the average, or people with self-perceived health bad or very bad have minus 11.4 less digital health literacy. So you see, we call that disadvantaged or vulnerable groups. And I think to identify this is very important for policy, because maybe we need to help these groups, different measures and interventions to do that. And of course, coming back to what you asked at the beginning, I am very much in favor of measuring personal population health literacy, but when it comes to improving, it's important to improve the situation and to improve the systems and the materials and the other things, and not rely that all 8 billion people who are living in the world will improve their personal digital health literacy. Yeah, next please. Now the determinants. Here you see just that the correlations besides with general health literacy are not so high. The highest ones are with financial deprivation, or with level in society, or with age in years. And we go just next into regression analysis now, please. Yeah, before you see, I think that's important to look at that, because if you have so many countries, it's interesting how the association of, for example, of educational levels with digital health literacy in different countries, or how it is with age groups. And we always have a mean here, the bigger line, and we have the lines for all these countries. Next, please, and we have it as well here for financial deprivation, and there's a very clear trend. And we have an association with use of digital resources where the trend is not as clear and very differing between countries. Now, the multivariable linear regressions, what do they show? There is a social gradient for digital health literacy by a model explaining on average 6% of the variance, but varying by country between 2% and 23% across countries. And financial deprivation is a predictor with on average the highest beta, minus 15, again, quite variable between minus 0.6 to minus 7. And that is significant for 10 countries, followed by age, and so on. Yeah.
Could I ask you if you might interpret this a bit further?
Yeah.
Because in a sense, I'm a little surprised with how big the R-squared variance is by country. You know, to go from 0.02 to 20.23.
Yeah.
What's your impression from this?
Well, I would say if it's very high, it must be a very unequal society, because these social indicators have such a big influence. And countries which are where there is more equality, there should be a lower R-square concerning these social determinants. That would be my interpretation. And you see in Israel, for example, it's just 5%. In Germany, again, it's higher. with 14%, and highest it's in Slovakia. But again, you see, we come into a very interesting realm here, how to interpret these figures concerning the background of the countries and the background of the healthcare system in these countries. Yeah. And for that, we would need quite a different kind of analysis.
Sure.
Yeah. Yeah, and at the moment we just have these figures, and for each country now sees how it is. You see, the study was done to help the politicians in these countries. They wanted to know something about health literacy in their country, what is difficult for people, what are the groups where it's most difficult, what is determining, and what are the consequences, and we did that. And we are very careful in comparing the single countries with each other. I think this kind of data can be used for some kind of benchmarking, but I think each country then has to see with which other country makes it sense to compare itself. Yeah.
Well, really, best with itself, really best over time with itself.
Yeah. If you have longitudinal data, best with itself. But if not, as usually in benchmarking, it's important. How are there countries where, for example, age is not so important? Israel, for example. Yeah. Why is in Israel age not so important for digital health literacy? Why is there more age equality in Israel concerning digital health literacy? And it's interesting.
It is interesting if you brought that up, because also in the 2012 study that we did with HLS, we saw the same thing, and it's different than what's going on in the rest of the world. And so we hypothesize there about why. So these are very interesting, and I agree with Michael, and I think it's what Jürgen has said all along. The objective is not to compare between countries, even though we all have all these countries on one chart, but we are actually hoping that each country will take the data and use it to promote health literacy and digital health literacy within the country. But let's Jürgen keep going, because we have 15 more minutes in the session, and you want to also leave some time for discussion.
I'm nearly at the end, but I think here I must make a comment. You see, if we would measure just in one country, we would say health literacy is like that. If we measure in so many countries, we really see how contextual health literacy is. Yeah, and I think that is research-wise very important to see these differences between contexts. Yeah. Even if part of that is methodological, still the context, there are certain trends concerning health literacy over different countries, but variation between countries is considerable. And I think that is one of the most important messages we can have from a study, from an international multi-center study like that. Next, please. Next slide, please.
Yeah. This is just about the general. This is the next one about the general. But let's keep.
With the general, we see that the general is so important. But let's just have two looks.
Right.
Unfortunately, in this concerning self-perceived health, we see that general health literacy is quite important, but if general health literacy is in the model, only in very few countries, digital health literacy still is a significant predictor. I think that we learn here. Next, please. If you look at the same for utilization of general practitioners or family doctors, we see here it's a little bit more even. Here, general health literacy explains less of the variance, but digital health literacy explains something more, and it's significant in some, but only few, but some more countries as well. And next, please, that is utilization of medical and surgical specialists. Here, even digital health literacy is a stronger predictor than general health literacy. But of course, compared to education, it is not so strong. Therefore, it's so important to see relatively how these effect parameters are distributed. Next, summary of main results. HLS-19 digital health literacy is a psychometrically acceptable measure, independent and related enough with other health literacy measures like general health literacy. Considerable proportions of general adult populations have low digital health literacy, with judging if the information is reliable and whether the information is offered with commercial interest as the most difficult tasks. Disadvantaged, vulnerable subpopulations with lower than population are older people, people with bad self-perceived health, with low self-assessed social status, with strong financial deprivation, and with low education. There is a certain social gradient for digital health literacy, with financial deprivation, age and level in society as strong as predictors. And use of digital resources is also a relevant predictor of digital health literacy. I didn't talk much about this model before. And fifth, only in very few countries has digital health literacy a significant effect on self-perceived health or utilization of GP family doctors or utilization of medical and surgical specialists when other determinants are controlled. And lastly, there are certain limitations, as I already said, concerning the methodology, which limits comparability of the countries. And of course, it's a cross-sectional study, therefore it's difficult to test strongly causal assumptions. But there is this one asset I already mentioned. Relatively standardized study in many countries shows the importance of national context for differences in results of health literacy. And with that, I am at the end of my presentation. Thank you so much.
So thank you so much, Jürgen. We're going to just have two more slides, Jürgen and I, about the recommendations that have come from it, and then we'll have time for some discussion. So what we actually would like to also make sure that we emphasize here is that the purpose, as Jürgen mentioned, the purpose of the study is in the end to be able to make recommendations so that policy and practice and research go forward. And so our group looked in depth into both the results of the study and also other work that's being done in the network. And we came up with the policy recommendations, policy and practice, and then you'll see some research recommendations. And these all will be included in an international report that Jürgen is working with his staff so diligently on, because they're coordinating all this data that next week will be launched. So there's we feel that we need to strengthen digital health literacy for all and prioritize populations with financial deprivation, less education, and in some countries, particularly among the older population. So the study helped us identify who some of the vulnerable populations are, and intervention efforts and policies to promote health literacy and digital health literacy for all should focus on critical digital health literacy skills, because we saw that was people feeling that they were weaker in, and increase the efforts to promote digital access to and digital interaction with healthcare systems, because there was also a place in the study that we saw that people thought that they felt less confident about how to access their healthcare provider. That was one of the specific items. To expand quality assured health information on the internet and in social media for populations, for communities, for opinion leaders, journalists, via mechanism for maybe even thinking about some kind of official stamp of approval. And let's not forget that these recommendations were coming out of this whole the corona pandemic era. So it is not a coincidence that we're recommending it for currently. Provide seasonally adapted health information in plain language, or we're trying to use the term clear language more than plain language. We might want to update this here. And develop communication strategies to reach specific groups of the population best via digital media. So we'll be seeing much more segmented. And as far as research goes, I think we're proud of the research, but we realize it's just one important step, but only one step. So we do acknowledge there is a lack of research on digital health literacy because the market has taken off so much faster than we can research for all the reasons that you know. So more resources should be allocated and expand research to include children and adolescents. There's some really great work being done in the European group, and it's become a global group, but we need to see more of that. Share research results with policymakers and health system managers. And we do that, but we need to do it more. We need to do it better. And if country comparisons are a priority, the next MPOL study should be conducted using similar data collection methods for all countries, because as you're going to mention, we really need to overcome some of those methodological hiccups that may be actually explaining some of the variants that we saw. So thank you all so much. And we've been talking and we want to hear from you. So firstly, again, Michael, thank you so much for allowing us to volunteer you as the first discussant. And of course, we want to hear from the audience as well. So I'm going to stop share. And we actually asked Michael to comment on a particular aspect that we felt was important. But of course, Michael can comment about anything he feels is important.
Well,
but we were concerned a little bit because of Michael's personal investment so much in the healthcare system. We were thinking maybe he can reflect about where does this join up, or where does this align, this kind of study and this concern we have with what he sees as in healthcare system, what's going on. That might be too broad of a question for you, and so you're welcome to answer in any way you can, or to comment on anything that's
sure.
just, come out of the
so I have to start by congratulating you guys. This is a tremendous effort. There's just a ton behind this, and of course all the different country teams and everything too. But you couldn't even possibly even have all the names even on one slide. It's impossible. It's a huge project. So thank you very much for sharing this, and it's really very good to see a lot of this. That the scales basically do work, hold together, and the fact that there's some top, that it doesn't really matter. The predictive validity is going to be at the bottom in terms of most health issues. At least that's where most of the research shows, in terms of what health systems actually need to be most addressing, just in terms of the health impact. But we have very, very few minutes. We have very, very few minutes. It's just 2 minutes because they're going to close this room and we have to go to the next room. And so besides congratulating you, it looked like fairly consistently judgment was one of the hardest things for people. And this really is a huge thing. I think it's cross-cutting, and it just goes right into the death grip of fake information, of false information. So this is going to be relevant to everybody. We don't even have time for you to do justice to discuss this topic, because it's a whole another hour to discuss misinformation and how to manage it. But I think in terms of, everyone's going to need to be working on this. COVID has proven that. The infodemic has proven that we basically turn a fire hose of information at people, a lot of which is not very valuable. And then we say, go for it, guys, have at it. And with extremely little support. So it's really nice to see you, Jürgen, Diane. Thank you very much to the interpreters. We have to run to the next room to just close out this conference. Congratulations again. I'm very much looking forward to seeing the reports. It's going to be more that, hopefully this will be a gift that keeps on giving, and won't be just a one time, actually provide a sociologic view. This is something that I think Jürgen has been such an important leader on. So congratulations.
Thank you.
Thank you so much.
And again, thanks our interpreter. Thank you so much for the several interpreters that have been with us this session. Thank you for your work.
See you in the next room. Bye-bye.
Thank you. And you're
bye-bye. Good night.
Late for you. Good night. And
for you too, Diane.